Hello. So I wanted to, on behalf of myself and Christina, share just an overview of the Lab Practical. The Lab Practical 1 is focusing on orthopedic dysfunction specific to the spine, posture, and gait. All interventions interventions of posture and gait that you've worked on during especially the first 4 weeks PTA 104 and lab and lecture, as well as getting a better understanding for providing care for someone with a problem related to a medical condition associated at the spine, right? Some impairments related to a spine problem. So these critical safety elements are consistent with what you have seen in PTA 101 and PTA 103, and even looking at our PTA 132 and 133. These red flags are those foundational skills that you learned as you were students a few terms ago. And so, however, this practical is going to look a little bit different because of the course and what the expectations are in terms of proficiency and competency in a simulated treatment with a person with a medical problem related to the spine. So treatment planning is just like in PTA 132, 133, and 103. Very looking at your organization. Do you know what you're doing before you start? Have you had your questions answered with the proctoring clinical instructor or those acting in the role of physical therapists? Do you understand the complexity of the case? Do you know those short-term goals as was reinforced in the screencast and what was discussed in lab and what's being reinforced all throughout the curriculum? Are you able to verbalize signs and symptoms of a possible emergency? We talked about this in lab, a significant, or a change, not significant, a change in bowel and bladder function, sudden loss of muscle function, and bilateral symptoms, pain shooting down both legs. So our expectation is that you are able to verbalize this to the proctoring examiner, in the case of this exam, myself or Christina. So you need to know these. And the rest you're familiar with. Communication is still worth 20 points. What we're seeing here is development. We want to see this development, really using specific information you're getting from the patient during the treatment and communicating your understanding of the questions they're asking, but also appropriately able to answer the questions. I want to emphasize that sometimes if someone asks a question, I don't know, it is fine to say, I don't know, but I will talk to my physical therapist or we'll get back to you on that. Because expect the unexpected, and you don't know what a patient's going to ask. And it's okay to say, I'm not sure, or I simply don't know the answer to that. And that is part of communication, is being honest. And you're all developing really well in using less medical jargon and more person-first language. So we're going to continue to see development and improvement in all these areas. Talking to the patient and getting what their goal of the treatment is for the day, and being fluid in your response to appropriately adapt your plans to meet the need of the patient. And the key word is appropriately. If a person is unable to stabilize the spine well and basic bed mobility, it's not realistic for that person to get up and run, for example. If the foundational spine stability isn't there, that is entirely unrealistic. So being able to have that conversation with the patient to talk about, for example, that working on sit to stands is part of pre-gait. And if the goal is to walk 500 feet today, and right now you're working on basic drawn in and spine stabilization for sit to stands, that is appropriate. But to share with them that is important, that you have good postural alignment in these transitional postures before you're able to run or to walk briskly, for example, or walk much farther than they have been. So application of interventions is where it's consistent with 133. It's really where we're really wanting to see some solid development as you're preparing to go into clinic. So this is why it's worth so many points. Okay, so integrates the principles of spine stabilization throughout the treatment. So I'm going to circle that 3 times. So that drawing in principle throughout the treatment, and to make sure that patient is at the right time engage in those muscles to provide support to the spine before they initiate walking, before they translate from a sit to a standing position, before they roll to the side to get at the side of the bed, and throughout some therapeutic exercise instruction, which we're wanting to see functional therapeutic exercise instruction, something that translates to what the patient will be using throughout the day. Gait training with the least restrictive device. I have confidence you know what that means. And in body mechanics, this is incorporating those spine mechanics and those postural mechanics of normalizing posture and creating symmetry versus asymmetry, and how a person is standing or how they're sitting, and to do so in a way that's going to help that person move in a much more efficient way. And this is where you're going to be flexible and adapt your teaching based on what the patient's needs are during that treatment, and knowing that what you expect may not be what you're going to see, and being able to make those changes to help that patient with that task at that moment, and to teach them and have them repeat those demonstrations to know that they are understanding what you just taught them. And movement principles in functional ways is a beautiful and appropriate way to do so. And time management, we're expecting you to have a solid 15-minute treatment addressing the plan of care and the short-term goals. So that wraps that up for the documentation piece. I am very excited to be using this lab practical rubric, and as you address orthopedic dysfunctions related to spine, and address posture, and use an intervention of gait to help this person that you'll be seeing this week.